Good afternoon and welcome to Baptist Health International's quarterly medical lecture. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator in today's lecture. This afternoon, I have the pleasure of introducing Rabbi Dr. Claudio Kogan, who will be presenting a lecture titled Implications of Bioethics in the 21st Century. Dr. Kogan is the Director of Bioethics Program at Baptist Health, South Florida. In his role, Rabbi Kogan provides system-wide interdisciplinary leadership, clinical practice, and staff development in the complex of healthcare ethics and patient rights. He oversees organ donation services, education, training, and regulatory compliance, and serves as a consultant to an on-call ethics consults, system-wide that is, regarding unusual, difficult ethical issues. As part of his duties, Rabbi Kogan provides advanced directives, education, training throughout the health system. As a member of the Baptist Health South Florida board and IRB board and vice chair, he assists the IRB review and approval of research proposals, expedited and exempt reviews, and attempt to attend monthly board meetings when required. Rabbi Kogan received his medical training at University of Buenos Aires in Buenos Aires, Argentina. He completed his internship at University of Texas MD Anderson Cancer Center in Houston, Texas, as well as an internship at Baylor College of Medicine in Houston. He's a certified mohel who is a professional who performs circumcisions and received his training at Bechur Shalom Hospital in Jerusalem, Israel. He holds 2 master's degrees in Hebrew letters and from Latin American Rabbinical Seminary in Buenos Aires, Argentina, and one from the Hebrew Union College in Cincinnati, Ohio, where he was ordained as a rabbi. In addition, he holds a Master's of Education with specialization in Jewish education, as well as a Master's in Bioethics from the University of Pennsylvania, Medical School of Pennsylvania, Philadelphia. Prior to joining Baptist Health, Rabbi Kogan served as founding director of the Institute of Bioethics and Social Justice at the University of Texas, Rio Grande Valley Medical School in Edinburgh, Texas. Rabbi Kogan is also a member of the ASBH Conflict of Interest and Research Committee and a member of the Florida Bioethics Network, as well as a member of the Central Conference of American Rabbis and an American Jewish Committee. He is fluent in English, Spanish, Hebrew, and familiar with French and Latin. It is such a pleasure having you, Dr. Kogan, with us. Please let's all give a warm welcome to Rabbi Dr. Claudio Kogan. Thank you so much for accepting our invitation, Dr. Kogan.
Thank you, Dr. Hakim, for the possibility of being with you today. Thank you, Alex, and thank you, Yamila, for letting me be. And I'd like to start this time, and I know that's going to be very, an hour that will be going fast, but nonetheless, I have to address this field in medicine, which is called bioethics, which is what I dedicated the last part of my life, my years, and the passion. And I'd like to share with the audience and welcome to all of you from where you are watching us. What is the implication, especially what is this field? Because when I'm talking about bioethics, usually people say to me, okay, what is that? So I usually try to explain this term with 2 parts, and each needs some explanation. One is the ethics part, which refers to the identification, study, and resolution or mitigation of conflicts among competing values or goals. The ethical question is always, what should we do? All things considered, and the bio puts the ethical question into a particular context. And always I am doing as well for Baptist clinical ethics, which is basically a practical discipline that aims to resolve ethical questions or disagreements that emerge in the practice of the healthcare. So this is briefly, and I'm going to go a little bit, I cannot work by myself. This is my team. This is the team that we have in Baptist, and we have our leader with Dr. Viamonte. We have coordinators that serve different hospitals, and we cover all the Baptist Health South Florida system, which is, as you know, 11, 12, 30, 13, 14, and we are expanding and we're growing. And each patient present, a conflict, and all of us would try to think about what will be the best for his or her treatment. So this is a team effort, and this is the whole team that I am part of. We're talking about bioethics as well. Sometimes it's mixed with social justice, to do fair, to do things, to do the right thing for the patient, to act in a justice way. So the goal of this presentation will be to define, which I started, to explain some of the tools that we use, and to share a little bit of some cases. Some of the things I'm going to go fast because I like to leave at the end of this presentation time for questions from the audience that I'm sure you may have. So what I said was, I didn't mention yet, but this term was introduced in the 70s, and then there was a revamp, and then we have different issues, different things that happen in the world history and as well in the American history that made this field growing. And today, each a convention that I'm attending, we find 3,000 to 4,000 people coming from different backgrounds. People are sociologists, doctors, nurses, philosophers, clergy. There's a combination, and everybody has a different role. Right now, I was asked to serve in one university in my capacity in bioethics, of course, with my faith background as well. So why we need bioethics? Because the need to do justice, to explain behaviors, and sometimes in the time that science is growing day by day, and we have different technological advantages that brings different good things to the humanity, and we before used to be 60, 70 years the expectation of life. Yesterday I saw a patient 102 years old. So look at the age of our population, which is growing, and the expectation of life is growing and growing. So, and these are important things that I like to stop by, because the Taski syphilis experiment happens in America, which was a population that received half of that. This was in the around the year 1940s. They had syphilis. Half of them received penicillin, half of them not. And this was kind of one of the bad precedents that we have in America, that made people kind of hectic and in some ways not comfortable to the science, because in that study, some people received penicillin, and everybody knew that they were having syphilis, and everybody knew that was the cure, that penicillin was the cure. But for experimental reasons, half of them did not receive. So this was a kind of the moment that since then, people start to, especially the African American population, started to be a little skeptic about why we need science. And guess what? In the last couple of 2 years, with the COVID and the vaccine, people thought about very clear or remember the Tuskegee syphilis experiment as a kind of, let's be careful. And not to mention, as a rabbi, to mention the Nazi experimentation that happened in World War II, especially with my people and people that were from faith that were not in agreement with the Nazi regime, suffered and were experimented, in the World War II. Another issues, another moments, we have the TNG 14112 trial, Dr. Shipman and DDT. These were other moments in the American history, especially the American medical history, that were not good. And those are the reasons why we need bioethics. So those are some of the key sources that we use, journals, that we have, especially in America, the Hastings Center and the American Journal of Bioethics, and other journals that we read and we, try to discuss, and we have with the medical community, the ethics community, discuss different topics that we face day by day. There are two important dimensions: the law and the professional guidelines, so we have to be careful always, and reflections of any case that we establish. How does it work? We establish knowledge of the relevant legal and professional guidelines, and and to exercise our ability to reflect. How? Using some philosophical theories. that some of you may familiar, some of them not. So briefly, those are consequentialism, deontology, visual theory, and principlism. And I'm going to go just to explain a little bit of each of them. The consequentialism is a theory that, the good part is that what is likely to produce more good than bad, consequences. We have, in the time of COVID, we have, 2 patients, 1 respirator. What should we do? The bad part of that theory is that what is likely to produce more bad than good consequences. And one of the examples is called utilitarianism, which is good is what produces the greatest utility for the greatest number. And this was one of the theories that was being discussed in the last 2-3 years with the pandemic. The problems. Can we know the likely consequences of our actions? What is the great uncertainty? Impartial, moral theory. Some will say that we have a duty to be partial. So those are one of the problems that we have with this theory. The next one is the ontology, which comes from the duty, and as well as known as the Kantian theory, the rules which express our duties. Killing someone to give their organs to someone else may ignore our duty to respect the person's right to live. What are the problems? Always following rules of conduct can lead to negative consequences. Examples: allowing a massive bomb to explode by refusing to torture someone. Not fabricating a research result might mean admitting that our study found nothing that is interesting. The other, virtue theory, focus on the agent of action rather than on the rules of consequences. To role model, which are the problems? It may fail to guide our actions, as there are no clear golden rules what can be applied. What is virtue might be virtue be vice. And then principalism, the 4 moral principles approach, which are autonomy, beneficence, non-maleficence, and justice. And those are, we call the bioethics principles. What is autonomy? Free will. We consider that each patient has the autonomy to decide what he or she wants for her treatment, as long as they have capacity, which is capacity they understand clearly which are the risks and the benefit of the treatment. What is beneficence? To do good. Always we are supposed to do good. Non-maleficence, do not harm, which we call in medicine primum non nocere, first do not harm. We as doctors, we know that if we establish a treatment, and even though the family may ask or request, we have to say sometimes, we cannot harm the patient. And even though the family say, do everything full code, if we think that we are violated some of those principles, we have to be careful. And last but not least, justice, social distribution of benefit and burdens. The most widely used approach in Western bioethics, and it incorporates elements from both consequentialism and deontology theories. So, in the, those a little bit about the autonomy is the right of self-determination is related to informed consent. The patient has to know, and he has to agree. That's why we call informed consent, what he or she will expect by a treatment, a therapy, a research, and those things has to be clear. Benefits to do well, to promote well-being, no maleficence, to do not harm, to avoid doing harm, and justice, treat like alike. So there are other theories which, I don't want to stop by, but, there are a lot of theories when we talk about ethics, but the 4 that I mentioned are kind of the main theories that we talk always. And those are some of the selection of prominent issues that sometimes in bioethics we discuss. Should scientists consider the possibility that the research might encourage bioterrorism? Some people said that, COVID, have done in a lab, was done in purpose, not in purpose. Those are questions that we ask ourselves. Regulations supporting good research, as well. What are health resources when insufficient in some countries, and how should resources be allocated? We just saw in the COVID time, and as well years ago with HIV, how we allocate or relocate our resources, for those in need, and in places when the resources are not sufficient. When to withhold and withdraw treatment, those are important, prominent issues that we discuss in bioethics. Should euthanasia be legalized in the US? Those are things that we have to consider and think about. So, is research on those who cannot give consent permission be okay? How should we access capacity and competence as well. Should human embryos be used to research? Should abortion be changed, as we discussed right now in our country? Should non-human animals be used for research? Is genetic modification acceptable? So those are things that we have to, understand, as issue that we have. Should people be encouraged to take their health more seriously, and why? What are the purposes of pre-implementation, genetic diagnosis, and prenatal diagnosis? Should treatment which are not recommended by NIH be available anyway, the National Institute of Health? So, and what we do for research, what are the risks, what are the opportunity and cost? And we remember always the ethical codes that we have when we study medicine: the Hippocratic, the Nuremberg Code, Declaration of Helsinki, Geneva, other guidelines. So let me go to a case that I always like to, because sometimes it's easy to talk about philosophy, but we have cases. So in this case, Mrs. Ojeda is a 64-year-old patient with diabetes who lives in a small town with one endocrinologist. Endocrinologist, Dr. Rivera, has a full practice and is not accepting new patients. Ms. Ojeda has very bad diabetes and has a very complex regimen that her family practitioner insists is beyond the scope of his understanding. Ms. Ojeda shows up in the office and insists to the office manager that she'd be accepted. What should be done? Usually when I have this talk, I have people alive. I'm sure you guys, we have almost 200 participants. Just think about, what if you are a doctor, what should be done? Okay, and let's go to the answer. Dr. Rivera is under no obligation to accept the patient, and this is something that usually I teach, when there is not urgent, when there is not an emergency, a doctor can refuse, a patient, and because let's say he or she is completely booked and there is no, so a doctor, again, if there is no emergency, can, and there is no legal obligation to accept the patient. I say that because sometimes people think, well, wait a minute, is that unethical? Well, but there's you have to do your best to take care of your patient and understand if there is no emergency, you cannot do any other thing. Second case, Mr. Garcia is a 60-year-old man with diabetes and hypertension. Yes, develops a renal insufficiency to the point of needing dialysis. He's equivocal about spending the rest of his life on dialysis, but he agrees to start. The patient is not depressed and is fully alert. 6 months after starting dialysis, he comes to realize very clearly that he absolutely does not wish to continue. You have no doubt that the patient has full capacity to understand the implication of this decision. What should you do? A time to think, and the answer is, you must honor the wishes. This is an adult patient with the capacity to understand her medical condition, although you may disagree with her judgment about the likelihood of her recovery, and she has every right to try. Okay, so this is the important things that we have to, I always teach medical students, residents, doctors, that this is important to have, the patient to have the possibility, to decide. You can explain pros and cons, the risk, the benefit, but at the end of the day, we have to remember patient's autonomy, which means they have to decide what to do. Another case, Ms. Jimenez, a 42-year-old woman who sustained a cervical spine injury at C1 and C2, leaving her paralyzed from the neck down the ventilator and ventilator dependent. She's very upbeat and cheerful. She said that she will get better and wants to be maintained permanently on the ventilator. You clearly inform her that she's wrong and she will never improve. She said she wants the ventilator forever or until she's cured. What you told him, in this case, her. Although there may be an emotional distinction between withholding dialysis and stopping it after it started, there is no ethical distinction between the two. If I don't like to play basketball, there is no legal distinction between my never starting to play basketball or playing a few games and in the cold anymore, in my right to stop. If I hire you to repair my house, but after a few days I decide that I don't like the work you're doing, I have the right to tell you to stop working on my house. You cannot say, sorry, once we start a job, we finish it, whether the owner likes it or not. I like it, the right to refuse to allow you to work on my house, and the right to tell you stop after you started. The patient has the right to stop the treatment. So those are some of the dilemmas that we have, and we call it ethical issues. What will cause the greatest good for humankind is something that we ask ourselves, and those are some of historical examples that we discuss as well in bioethics. Abortion, contraception, kidney dialysis, organ transplant, artificial ventilator, in vitro, cloning, genetics engineering. Death and dying, pre-birth issues, issues in human reproduction, human cloning, stem cells, transplant. And there was always, a case of reproductive cloning, which years ago, 2 decades, I was reading about that. I wrote from a religious point of view and as well from a medical point of view. At that time, I thought it was, talking about science fiction, and it was over 20 years ago, and we are in a different spot today. We're talking about right now about genetic engineer. We talk, years, just 1-2 years ago, I'm talking about the issue of genetic editing. This was other things. Another important hot topic. I do believe that, I don't know exactly when, but I'm truly convinced that in a couple of years, and I'm not a prophet, neither the son of a prophet, I envision that everybody will go to a doctor instead of giving, a drug or prescribe something. We will talk about, this is my genetic code. Could you please fix it? And we'll have to discuss if we have to change cytosine, guanine, and adenosine, and thiamine. So those are the things that I envision that will happen in the very short future. Again, I cannot say when. And that's, cloning. And as always, we talk about that, and probably in some ways this topic is every day may have different, advances. 2 techniques, embryo and nuclear substitution. Embryo splitting, the clone is usually used for tests of anomaly and will be destroyed subsequently. And we have therapeutic cloning as well, which day by day, this is, medicine is, advancing very fast, about involved stem cells, enhancing our understanding of human development and serious medical conditions. I have 2 kids. One, she's almost 17. At that time, I decided to froze her placenta and thinking, well, what will happen? And today, this almost 20 years ago, 20 years later, we have a lot of advances in that field as well. We have nuclear substitution, and we talk about changing of sex, changing of different things as well. Is it moral or right for patients to clone their beloved children who die young? This is one of the questions that not so long ago, before I came to Baptist, was a case that was not about cloning so much, but about using the sperm of a child who which the parents requested that if after the child was died, if they can, he was in 18, 19, if they can use, they can froze his sperm as well. Implantation, diagnosis in vitro, general decisions, designing babies. Those are things that, you may think that could be, science fiction, but those are things that when we talk about, bioethics in the 21st century, I always try to remind everybody that those are things that if we are not discussing right now, very soon we will have to talk about. DNA profile, DNA chip identifies genetic predispositions, DNA banks, transgenic plants, and this is something a new field as well that we have. Are they safe to eat? We are talking about, we see that how they will affect our ecosystem. Transgenic animals, engineered animals. So those are things that we talk about in bioethics. Xenotransplantation as well, harvesting organs from animals for organ transplantation into humans. We talked about recently about a pig, heart of a pig transplant to a human body. Somebody asked me from a Jewish point of view if that was okay or not, because we, from a Jewish point of view, we are not allowed to eat, in this case, pig, but we're talking about pig insulin or a heart from a pig that can be used to save a human life. So always the important thing is to find a balance, what we could, what we should do, and what are the pros and cons that we have in this area, and especially, and the other point is stem cell research. We have different ways: embryonic cell, fetal cell, adult cell. And then EAC is the most promising for treatment, and therapeutic cloning can avoid the problem of immunological incompatibility. Genetic testing create the necessary psychological distress, discrimination, confidentiality, social stagnation. Those are the ethical issues that we face when we talk about this topic, especially prenatal screening, sex selection. I want to, we may face situations, if not now, in which couples may say, I want, my son or my daughter, I want to have a baby that will be, with such, color, such eyes, and we have to be careful. There was a, long time ago, I saw a movie which was the Kids of Brazil, which was, about experimentation and about to have what was called the perfect race. So genetic engineering, eugenics is another topic that we talk about in bioethics, especially in this 21st century. So what we do when we have the any ethical case, the first thing we do is we have to gather the facts. If we don't have facts, we don't have a case. And then we have to define which are the ethical issues that we have. It's an issue because the disagreement between the medical community and the patient what to do. It's an issue of patient's autonomy. It's an issue of capacity, where the patient would think that may have or not capacity. It's an issue of a living will, that the patient wants something and the healthcare proxy, or the healthcare surrogate wants a different thing. We call healthcare surrogate is the person that, a patient will designate, to when the time that he or she will not be able to say what they want, he or she, the surrogate, needs to say what the patient wanted. And I will encourage, if there is, one of the takeaway from this topic is, no matter where you are, no matter in which country you are, I will strongly encourage to speak with your patients, or even though from your perspective, always to talk about your loved ones. What if you are not capable and you don't have the capacity to say what you would like? Mention, identify a person who will be the person who will be the one who will speak on your behalf. And that's an important thing. Sometimes we don't pay attention, and especially in the Latin community, we don't talk about those things. But things like that could happen. I always tell the story about 5 years ago. I was in Miami, stopping in a red light, 7 a.m. in the morning. All of a sudden, somebody bumped into my car. I had the seatbelt. I was taken to the hospital, unconscious. And thank God I'm here to tell the story. And this could be and could happen to anybody, and especially if you drive here in this place of the world. But I'm sure if you are in a different place of the world as well, accident could happen. So we always have to identify somebody before when we have the capacity to do so, to be the person who will speak on our behalf. So go back to this, with this summary of the steps. It's important that we gather the facts to identify the ethical issues, to identify, who are the stakeholders, who are the affected parties, to see the consequences, to see which obligation, which principle is involved in the issue, and to consider our character and integrity, and then, to see what will be the potential action will go, to see what is your gut feelings, what is you think that is happening in this case, and then, decide on the proper ethical action to be prepared to deal with opposing arguments. When we gather the facts, let's not jump to the conclusion. We have to ask questions of what, who, what, where, how, and why. However, facts may be difficult to find because of the uncertainty often found around ethical issues. Some facts are not available. Assemble as many facts as possible before proceeding. Clarify what assumptions you are making. I had, recently cases I faced in which the family wanted the loved one to be in the hospital, intubated, and for a long time because they were receiving a check from the government. And if we were able to, to stop and, to let the person pass away, he in this case will not receive any more checks. So always there are facts, there are things that we may not know. And usually, we have to explore the family dynamics and to see what we are missing, which are the facts that are important for this case, and how we have to have, to maintain and respect what the patient wanted or the patient would have wanted about his or her treatment. And then identify the issues, don't jump to solutions without first identifying the ethical issues, define the ethical basis for the issue, that we want to focus. If there are multiple ethical issues, we have to do one at a time. Identify who are the parties here, the stakeholders, who are the primary person, who is the secondary, and what are the stakeholders for the issue, perspective taking, and always to think about what are the things that we are not seeing and how we, I always say that we have to have empathy. What does that mean? That we have to stand in their shoes to see the picture. And next, the consequences. Let's think about potential positive and negative consequences and which are the magnitudes and the probability of those consequences. Short-term versus long-term, symbolic and secrecy, symbolic consequences, secrecy, what are the consequences if the decision of our actions become public? And sometimes, I found that some doctors are afraid of proceeding because they are afraid of the family. I found sometimes family that they are kind of very aggressive. And we as the medical community, we have to think about what is the best for the patient, and as well, how we have to be careful to not violate our principles as healthcare practitioner, as healthcare team. Remember justice and the obligation that we have. What are the obligations that are created because of particular ethical principles? Do not harm. Don't do unto others as you will have them do unto you. Do what you will have anyone or in your shoes do the next given context. And what are the obligations that are created because of the specific rights? And what are the more basic and secondary in nature? And what types of rights are involved, negative or positive? Those are the things that we have to think about when we go through this process. And to have, our, what I call character and integrity, which means that we have to have, what our relevant community members will consider to be kind of decision that an individual integrity, will make in the situation, and what the specific virtues are relevant in these situations, and disclose the rules and what will do if the New York Times reported your action and everyone was to read it. So I always said, what you do, always remember that, would you advertise this decision? And if you say not to yourself, just be careful and think about, again, the whole process just to come to a better outcome. So in a nutshell, these are the, what I call the May ethical work framework to identify ethical dilemma, to identify the actors, what can be done, what are the ethical principles in conflict, and what, the most important, what should be done. So I was trying to explain to you, a little bit about the what is bioethics, what we do as clinical ethicists, and and always let's think about to concentrate in the best for our patient, and what if that patient is our father, our mother, our uncle, our grandmother, and what we should expect that he or she will receive. And those are the things that I always like to recognize and to mention. Not so long ago, I visited a patient that, as I said before, has 102 years old, and the patient is intubated, because, a doctor, probably, I will say, has the lack of experience to say no, and the patient is in the catalectic stage, and the patient is dying. And what is the purpose of maintaining that life? And what is the purpose for the family to continue the treatment? And I had family meetings when I explained, and sometimes it's hard to understand that we as the healthcare team, we will do our best to work for life. But sometimes we have to recognize when we cannot achieve that because of whatever the issue, to see and to say and to be able to say, no, I'm sorry, we did our best. It's important that, as I always learn this, principle, life is a journey and death is a destination. All of us eventually will die. We don't know when, but we have to always, when we talk about bioethics, we have to understand that is a limit, and we have to always to make sure that the medical community understand that even though sometimes we may see that a failure, that the patient is dying, sometimes we have to ask ourselves what is our field, what is our position. And I do believe that we have to help the patient. We have to do our best so the patient will recover. But sometimes we have to understand that if we cannot do that because of the aging, because of situation, because the patient is starting what we call a systemic organ failure, we have to recognize that it's part of life as well. And we have to let the patient die with dignity as well. And in my experience, I see that sometimes for different reasons, the medical community, has tough situations to understand the concept. Sometimes I've seen is legal issues. I am afraid to be sued because I didn't do A, B, and C. Sometimes it's because the family is pushing me and I want to do our best. Sometimes because I feel that, I am completely knowledge, I had experience to save the patient because I did X amount of surgery or because whatever. But we have to, to step back and to see if what we are doing is the right thing to do, is the medical thing to do, is the proper treatment for a patient, and if not, we have to be, have the wisdom to say, you know what, I'm sorry, this will not work. And we call in medicine, that concept futility. What does that mean? That you do over and over and over, knowing that, it will not help the patient. I always learn when a patient died, there is what we call 5 minutes golden time to do CPR, to try to restore his cardiopulmonary functions. And I've seen people doing after 20, 30 minutes. So if we know that 5, 6, 10 minutes are the time, and if we know that we go over and over and over, it's important to understand that we do our best, but we are not God. We don't have that power to make miracles. And I always say, I do believe in miracles, but I do believe in the power of science, in the experience of our medical community to make sure that we use, and as we are partners with God creation, to use our wisdom, experience to help those in need. And I believe that is why all of us, or those who are in the medical profession, we did the Hippocratic Oath.
Dr. Kogan, what a beautiful presentation. I have always enjoyed bioethics, and I honestly will tell you, and I think I speak for all the students and the doctors present, that perhaps this is one of those subjects that we do not necessarily take for granted because it touches our own morality and it touches us all from different perspectives. As a matter of fact, it is something that it's worthwhile reminding everyone, and how you concluded by stating that it is the belief in science and, of course, the partnership that you have in your own mind with God as of what the right thing to do for a patient is. Now, thank you for that incredible presentation. But I wanted to just, as we wait for some questions from the audience, I wanted to talk about some of the dilemmas that we encounter on a daily basis in a hospital system like ours, or perhaps throughout the world, that is a very common denominator for all of us. Again, our own morality sometimes tends to play a great role in this. And we do have our internal biases that sometimes we fight with simply because some individuals or some groups might not necessarily agree with what the right thing is, what the right thing to do for the patient is. And you touched upon consequentialism, which is perhaps one of the most common dilemmas that we encounter in clinical practice. And that horrible fight between the good and the perception of bad actions that a physician or a group of clinicians need to incur in. And you did mention the example of the COVID dilemma that we all face throughout the world. This was not unique for Florida or the Caribbean. It was throughout the world. It was an awakening for everyone to realize that we do not have it all and we do not know it all. Okay, and then to be encountering those type of dilemmas in which you had as a physician had to select between who is going to be treated versus the one that is not going to be treated either by intubation or provided a medication. Then later on, we encountered a not so harsh of a type of dilemma, but we did encounter in regards to who should get vaccinated because of the limited amount of vaccines. And so it touches on so many levels, not only in our medical profession, but also in society. It's a societal type of approach to consequentialism. So my question is, how would you actually summarize for the student doctors that are about to come out of school, fresh or freshly minted as physicians? How would you recommend for them to use their own biases, or how would they prevent their own biases from actually incurring into a decision that perhaps be perceived as perhaps a bad decision?
Thank you, Dr. Hakim. That's a great question. My first thing is to be aware that we are not alone. And that's one of the first steps that we need to take. And when I say we, I'm talking about the medical community, or those students hopefully will get inside the medical community, which was a kind of a paternalistic, idea of the doctor as God. And sometimes in the Latin world, still the doctor is seen as God. What the doctor says, I will do it. So be aware of that. Be aware of the power that you have. And when you face decisions that you, as I said before, are you comfortable to advertise in the New York Times or any media your decision? If the answer is no, ask the help sometimes of another colleague, or what I call an ethics committee. That is, a fundamental committee that has to be in every single medical school, institution, hospital. Thank God in Baptist, we do have that, and it's a committee that is composed by people from, the science, and ideally a committee that has to be, part of people from the faith community. Whatever I have ethics committee, I always request, a pastor or somebody from the faith community to be involved in that committee as well, just to cover all the grounds. An ideal will be a member of the community as well to be part. So remember that unless we're talking a decision that is an emergency that you can have to decide right away, and even though, as I mentioned before, a case that I faced just recently, a case of a 100+ years old lady, which 3 a.m. in the morning, the doctor decided to intubate that patient. And this was probably a decision that I will call a lack of experience of that professional, because even though we believe in life, that patient particularly was not kind of, we didn't do any favor to that, even though from a medical perspective, from a scientific perspective, we say, well, this is the decision. So we have to explore all of the factors, and especially, and I think that is what COVID taught us, that we need to explore. We have to think about proactively and not reactive to a measure. And if there is something that we have to do right away is, I believe, unfortunately, that we may have another COVID situation in the whole world. I think COVID is just the beginning. We're going to face, situation that we will require, to be proactive and to have those committees available to be, be heard and to be working towards what we do if, what are the measures we take care. One of the big questions was, what if we have to take care, first a medical person of the team, his family, or the general community? And this is something important. There was a big discussion, yes or not. A law enforcement person should take present, before another, human being, yes or not. And all of those are pros and cons that we have to remember. So once again, how to those who are coming to the field, how to make sure that those bios are not taking, and are the motor for them, just consult with others.
Great advice, Dr. Kogan. And one thing that comes to mind that I think that now finally we're instilling in all our practitioners is the fact that, yes, we do not know it all. And that it is okay to question ourselves in regards not to our integrity. However, it is important to question ourselves if we are doing the right thing for the patient. The interdisciplinary team conferences, for instance, what a beautiful concept that has always been taught to us, interconsultation or request a favor from another colleague to look into a difficult case. And it's now when it's coming to fruition, really, that we are seeking advice to peers, same practicing peers, to understand exactly what the limitations of a specific treatment will be. So dilemmas such as that we're constantly encountering. One that is perhaps one of the most frequent dilemmas is, and you did mention that in our ethics committee, not only we have lay people, but we also have religious representatives such as yourself, or Catholic priests, or pastors, or what have you. One of the biggest challenges that sometimes we encounter as well when we admit patients are, for instance, those that cannot, due to religious reasons, cannot receive transfusions, such as in the case of Jehovah's Witnesses, for instance, that we need to respect their wishes when they say we cannot get transfused because of our religious beliefs. Now, this is perhaps one of the biggest conundrums that physicians will encounter in one of our hospital systems and perhaps around the world when they encounter a pediatric case that we understand and we know that the kid will decline in functions rapidly and probably will lose his life or her life if we do not transfuse, despite the fact that there are alternatives to transfusion. So obviously, aside from the legal implications and the probable dilemma and problems that we'll encounter, that we'll be encountering with the family and the hospital, what are your recommendations when it comes to religious practices versus the clinical right thing to do, in quotations?
Well, always I have to say, if it's an emergency, everything change, and I prefer that we have a case, a legal case, because the wishes and the faith was not respected, but the life was safe, than not to avoid by that. So an emergency is one case. A case of pediatrics, if we have to do it, the kid, in emergency again, will be transfused. If we have the chance to do a different way, we use plasma or other components that the family will allow and will talk about. But there are different situations: emergency, a child, an adult, and we have to understand those things. As long as we can, go and respect, we'll do it. If there are certain things, that are, a kind of in between, I will be very careful, and I will always say, first of all, is the human life.
Mm-hmm. And that's a great advice. And the underscore and key indicator here is emergency. We can always deal with legalities later on.
And I give you another example. I had a case of a patient that was supposed to receive, not an emergency surgery in the day of Yom Kippur, which is the holy days in the Jewish faith. And there was a conversation with the doctor, and they moved the surgery to another day. So we have, always, I always said, I like always to respect the faith,
Sure.
but when we're talking about emergency, it's a completely different category.
Yep, and it takes a different turn, especially when there is an urgency to act upon a particular condition that will require not only your intervention from the ethical committee, but more importantly from the legal standpoint, and carry on activities with an urgent request from a judge to do something, which is going to get us all in a tremendous dilemma eventually. But doing the right thing is consistently what we need to do. Thank you, Doc. There is a question from Christina. She goes, does one have responsibility to intervene if one knows that a colleague's decision is detrimental for the patient?
Yes, of course, we have to do our best to say that, sometimes that decision of our colleague could be, because he's going through a difficult moment, and I had a case in which one practitioner was drinking, and the decision was not correct. So we call in that way impaired physicians. But I will do, I will strongly recommend that colleague will be, I usually sometimes is talking to his or her supervisor, just to, and sometimes, to be careful because, we think we have to do our best for our patient.
Mm-hmm. And always, again, you said it very clearly, do the right thing. Okay, if it is, in my case, and this is me saying out loud, if I see something that is going to go wrong, I obviously can slap the hand of that person, regardless of how bad I'm going to be viewed in the dining room with all the doctors later on. But we have to do the right thing for our patients. So I suppose it is our duty to act accordingly and follow, as you said, Dr. Kogan, follow your gut. If you do have a gut feeling, do something about it. Right. Androla has also a comment or a question. She says, thank you. If a patient has a living will and family members are aware of it, would verbal be enough? I guess verbal statement be enough for a living will has to be present to the hospital. I'm sorry, this is a little bit confusing, but I guess what she is asking is, would a verbal statement be enough to represent the will of a patient?
Well, I usually prefer that will be written, because sometimes, family members, we don't know the dynamic, and, we have, issues about what the patient wanted or not. If we don't have written, a verbal will be another important step, but I will be, I usually will recommend before you take that to understand a little more about if you perceive in your gut feelings and there is something in the dynamic of the family when it's presented that you have any kind of suspicions.
Okay, well, we have a question that perhaps is not necessarily clinical in nature, but it is societal, however we see it. Jose is asking, what do you say about homosexuals having children? Now, that is, Jose, a kind of a personal question that you're posing here, and perhaps it might be a dilemma for some societal groups. But what would be your opinion on this, Dr. Kogan?
I respect every sexual orientation. If they would like to have, kids, I will, I have no problem with it. And I always, now, if I go to the faith, I am a liberal rabbi. Some of my Orthodox colleagues will not agree with me, and especially talking about the Leviticus chapter 18 and 19, which is, this brings us to another religious conversation, and is the way that you understand the Bible. You say, the document is clear, the Bible is clear, this against God's will. and we have another different conversation. It will take us another big hour. I'd be happy to someday talk about that. But if the homosexual couple decide to have a kid to create a family, I will have no problem with it.
And Dr. Kogan, thank you again. That was somewhat of a very personal opinion. But again, it boils down, everyone, it boils down to what is the right thing to do. Okay, it is not our own biases or our own beliefs. There is already written statements, as the good Rabbi just mentioned. And each one of us has the rights to either follow that path and beliefs and practice it in our own life, but we have no reasons why we need to be judgmental towards others. And if it is a legal type of scenario in which is acceptable and permissible to have babies, then be it. We are no one in society to actually stand under way of someone else, especially because already ethics and morality came into play before a legal announcement was made. So
I have to mention that sometimes, and knowing different languages, brings me to understand each culture in a different way. I wish that people who read the Bible will read the Bible in Hebrew, because this will, avoid a lot of discussions about topics that we're talking about: homosexuality, abortion, in vitro, beginning of life, and that's each of those topics brings another conversation by itself. And I always said, please, to start a discussion, let's study and let's learn with the source and how the source was written. Because when you have another translation, it's just a word make a difference, and a comma is a different understanding.
Throws it completely out of the realm of the understanding that we need to have. You're absolutely right. But again, it is, Jose, it is a personal question, and each one of us has the obligation as a professional to believe in whichever way an individual should practice or take upon that particular subject. So again, it is more of a clinical scenario that we're talking here. Ricardo is asking, what is to do when a patient has what are you to do when a patient has a request, but the next of kin is not willing to fulfill the patient requests?
Yeah, that's a great question, because it's a real question that we face almost daily. We have to always abide by the request of the patient. The wishes of the patient, as I share with you, one of those cases is the one that we have to always, respect. That's why we believe in, which is called patient's autonomy. And sometimes the family may disagree. Sometimes the next of kin may disagree, but we have always to respect patient's autonomy.
Dr. Kogan, again, you have a very challenging and one of the most interesting departments, being in bioethics and having to witness individuals such as yourself leading us all into the right thing to do and bring us all to the level of the questions, the initial questions: what matters most? What is the dilemma that we are talking about? And eliminating the white noise, eliminating the noise around it, and the biases that are surrounding it is perhaps one of the biggest challenges your committee has. And I thank you personally, and thank you on behalf of all our team for what you do on a daily basis with our patients. It's not an easy job. And,
thank you, Dr. Hakim, and thank you to the Baptist Health South Florida system to honor me to be the director of the Bioethics program, which is, makes and talks high from this organization. And, I really enjoy every single day of my life working with my team. Thank you, Alex. Thank you, Emilia, for the possibility of being, and thank you to the almost 200 participants in this webinar. I look forward to another discussion on our topic. And once again, thank you very much.
You said it better than I did in the past, Dr. Kogan. It has been a pleasure. Thank you so much for accepting our invitation, and to all of you for participating and for your great, great questions. I want to encourage all of you to continue looking into making certain you do the right thing consistently for our patients. And best of luck in the next semester, and have a phenomenal summer to all of those that are finishing the semester. We look forward to seeing you at our next quarterly medical lecture scheduled for Wednesday, August 24th, 2022. If you do have additional questions, please make sure to send them to bhiwebinars@baptisthealth.net. That is bhiwebinars@baptisthealth.net. We would love to ask Dr. Kogan on his opinion from any ethical standpoint or ethical dilemmas that you might encounter in your practice. Thank you once again. Have a great afternoon. Thank you, Dr. Kogan.
Thank you once again.